And we'll be getting started in just a minute. Gonna let people get signed on.
No problem.
Okay. Well, welcome everybody. Um, Welcome to our provider network meeting. It's been 2 months since our last one, which is hard to get used to rather than seeing everybody monthly. Um, as you know, I'm Jill Harlan with the CLA, and today we have a great topic we're discussing, racial disparities in liver cancer with Dr. Andrea Branch. Um, we're very excited to have her here today. Please remember, if you have any questions or if you'd like to have any discussion, please feel free to unmute yourself. Or if you do not want to speak, you can certainly enter into the chat and I can relay those questions to her. All right, Dr. Branch, if you want to get started, you can.
So I'm really glad to be interfacing with the Community Liver Alliance. I think what you're doing is really, really important. So thanks so much to Jill for inviting me. What I want to convey today is that hepatocellular carcinoma in African Americans has this very unfortunate dichotomy where the liver disease is indicated by liver cirrhosis is less advanced at the time of development of liver cancer, but survival is worse. So I really want to try to convey the sense that we've got two sides of a coin, and to try to bring some understanding to what these two sides are reflecting. So a little background on liver cancer. Hepatocellular carcinoma is the main type of liver cancer. And as you can see by this blue arrow, liver cancer deaths globally are fourth in line for all cancer deaths. And liver cancer deaths are actually very close to colon cancer deaths and stomach cancer deaths. Far below lung cancer, but after lung cancer, really in this group of the largest number of cancer-related deaths globally, so very important. And unfortunately, although the number of liver cancers is very great, survival for people who have liver cancer is not high at all. And it really hasn't improved all that much over the years. So in the last 10 years or so, it's only improved from about a 3% 5-year survival to about a 20% 5-year survival. So it's very common as a type of cancer, and survival is very low. So most people in the United States who get liver cancer have viral hepatitis, and hepatitis C is the predominant liver disease in patients who develop liver cancer. So I know there's been a lot of attention in recent years on non-alcoholic steatohepatitis, NASH, and non-alcoholic fatty liver disease. And there's been a lot of concern that NASH and NAFLD would become a major driver of hepatocellular carcinoma. But as you can see in this graph, from about 2008 to 2016, NASH-associated hepatocellular carcinoma has been pretty flat. Hepatitis C-related hepatocellular carcinoma has also been pretty flat, and it's about 2/3 of the cases. The liver etiology that's really probably increased the most is alcohol. But Hep C remains the most important driver of liver cancer-related mortality. And you have to see from this graph that it's by far the leading driver of liver-related mortality, followed by alcohol and hepatitis B. And then down here, you see the liver cancer-related deaths from NASH. So if this surprises anybody, or if you have questions, just speak up, because as I say, I think there's been a lot of attention to NAFLD as a hepatitis C, as an HCC risk factor. And so it's important to remember the massive importance of viral hepatitis. This is just more information. This is looking globally at the underlying liver diseases in patients with liver cancer over here, or liver cirrhosis. And you have hepatitis C in green for both cirrhosis and for liver cancer and cirrhosis. And in both cirrhosis and hepatocellular carcinoma, hepatitis C is the leading underlying liver disease. This is some very recent data that looked at alcohol-associated liver disease mortality in the United States. Investigators were particularly concerned about the impact of the pandemic on liver-related mortality. What they found was that there was a tremendously bad impact of the pandemic, especially on American Indians or Alaskan natives. But for African Americans, the amount of alcohol-associated liver disease mortality was generally on the lower end. And certainly we're doing very well here in New York. So, important message that hepatitis C can be cured. We have wonderful antiviral medications. We say 1 pill once a day for 8 to 12 weeks. You can cure a life-threatening infection, so we really want to take advantage of that. Unfortunately, the risk of liver cancer persists even in people who've been cured of hepatitis C, and the risk is greater if patients already developed cirrhosis before they were treated for hepatitis C. This just shows some of that data. Excuse me. And I just want to highlight how we determine the cirrhosis and fibrosis stage of patients. In this study, the investigators made use of what we call the FIB-4 score, which is a non-invasive index that takes age, AST, platelet count, and the square root of the ALT, and can be used to estimate fibrosis stage. And what the investigators found in this case was that depending upon your stage of fibrosis, before you were treated for hepatitis C, you had a higher or a lower risk of liver cancer after you were cured. But unfortunately, the incidence of hepatocellular carcinoma remained quite high, even in people who were cured. So it's important if you have advanced liver disease and you're cured of hepatitis C to continue to screen for liver cancer. Unfortunately, the incidence of liver cancer is about twofold higher in Blacks than in whites. And also, unfortunately, although the incidence of hepatocellular carcinoma is decreasing in most groups in the United States, so you can see over time, this trend is looking at the change. So we have a significant decrease in the incidence of HCC in whites, a significant decrease in the incidence in Hispanics, significant decrease in Asian Pacific Islanders, but in African Americans, there is no statistically significant decrease. There's a slight decrease, but it's not statistically significant. So even though HCC incidence is decreasing nationally, it's not decreasing significantly in African Americans. And I just want to highlight a little bit. People often say that liver cancer is the most rapidly increasing type of cancer in the United States. That used to be the case, but actually there was an inflection point in around 2014 And in about 2014, the incidence started to come down. So in addition to having higher incidence, African Americans also have higher HCC related mortality. This data is from a national study, and it's important because the investigators adjusted for many, many variables, such as the type of insurance, the zip code, so controlling for exposures, education, underlying disease etiology, and even adjusting for all of these factors, African Americans still had higher HCC related mortality. So it's important to get to the bottom of what is driving this increased mortality risk. This just shows one example of data that we see frequently, and that is in this particular study that was done in Texas, that the mortality for patients with HCC is highest in Blacks. So how can we reduce HCC related mortality? Well, the most effective way is to reduce the risk by treating viral hepatitis. So it's really critical for everybody to be screened for hepatitis C and hepatitis B. So the CDC recommends screening at least once in a lifetime for virtually all adults for both hepatitis C and hepatitis B. For hepatitis C, most cases can be cured with antiviral drugs, one pill once a day for 8 to 12 weeks. Hepatitis B cannot currently be cured if you have chronic hepatitis B infection, but the cancer risk can be tremendously decreased by antiviral treatment. In addition to reducing viral hepatitis, it is helpful to reduce smoking, which is a kind of underappreciated cause of liver cancer. Exposure to aflatoxin, which is not much of a problem here in New York, but down in Texas and countries that border Mexico, there is more aflatoxin exposure. Alcohol consumption contributes to the cancer risk, and also type 2 diabetes is a liver cancer risk. So besides reducing exposures, it's also important to strive for early detection by enrolling high-risk patients in liver cancer surveillance programs. And we need to ensure that the guidelines that we have for surveillance are equitable and really address the fact that the disease presentation is not the same in all people. And our work suggests that the guidelines may need to consider race, as is under discussion for lung cancer. So this slide shows some information about lung cancer surveillance. It's known that a significantly lower percentage of African American smokers qualify for lung cancer surveillance than white smokers. And despite having smoking fewer cigarettes per day and having a lower pack year history, African American smokers have a higher risk of lung cancer than white smokers. So the guidelines would need to be reduced to 20 pack years for African American smokers, as opposed to the current 30 pack year threshold, in order to be on a par with white smokers. And this is really under investigation and being advocated that these guidelines need to change. So I want to present some background information about liver cancer surveillance, the requirements for enrolling in surveillance, the recommended methods of surveillance, and differences in guidelines across agencies. So most agencies, the American Association for the Study of Liver Disease, AASLD, for example, really only targets screening for people who have cirrhosis. And that is because cirrhosis is a very strong risk factor for primary liver cancer. And about 80 to 90% of all cases of hepatocellular carcinoma occur in people with cirrhosis. So what exactly is cirrhosis? Well, essentially, cirrhosis is a combination of scarring and other anatomical changes that occur in the liver in response to injury, usually chronic injury over many decades. So if you start with a normal liver, and then you have, for example, viral hepatitis, or you have NASH, or you have alcohol, this injures the liver and you have scarring and you have progression toward cirrhosis. And as I mentioned, about 80 to 90% of people who develop hepatocellular carcinoma develop cirrhosis before they develop hepatocellular carcinoma. And that fact really opens up the opportunity to identify a high-risk group to engage in surveillance. However, 10 to 20% develop hepatocellular carcinoma without first developing cirrhosis. And we certainly want to find ways to identify those high-risk patients and enroll them in surveillance as well. And particularly, this is important for African Americans because they have more of a tendency to develop primary liver cancer without first developing cirrhosis. And I just want to mention that the incidence of hepatocellular carcinoma varies depending upon the underlying liver disease. So people with NASH and alcohol cirrhosis, their annual incidence of hepatocellular carcinoma is less than 1%, whereas when the underlying liver disease is chronic hepatitis C infection, about 3% of people with cirrhosis will develop hepatocellular carcinoma every year. So this is a absolutely astonishingly high cancer risk, and we really want to get these people into surveillance. This slide goes over the AASLD surveillance guidelines. So these guidelines point out that adult patients with cirrhosis are at the highest risk for developing HCC and should undergo surveillance. Surveillance should be done twice annually by abdominal ultrasound with or without alpha-fetoprotein testing, which is a blood test. The risk of HCC for patients with HCV-related cirrhosis who are cured by antiviral treatment is lower, but not eliminated, and therefore patients with cirrhosis and treated HCV should still undergo surveillance. And the risk of HCC is significantly lower in people with HCV or NAFLD and no cirrhosis compared to those with cirrhosis, and the AASLD does not recommend surveillance for these people. And this is definitely a problem because, as I mentioned, 10 to 20% of people who develop liver cancer don't develop cirrhosis first. Cirrhosis surveillance is recommended for selected groups, but none of the groups that are in this category of exception really applies to US-born African Americans. So I'm just going to pause to see if by any chance anyone has a question.
Yeah, it's Jill. I was thinking with I guess with all the new HCV drugs that we're using to eliminate hepatitis C, I'm surprised there's not more of a decrease from 2018 to today. But do you think that there's a disparity in African Americans receiving those treatments that would also increase this disparity for them to have HCC with the hepatitis C infection, not obtaining the
I
drug?
think that's a terrific question. And I think what you say makes a great deal of sense. And probably that is going on. But I'm afraid something else is also going on that's quite dark and grim. I think one of the reasons, I don't have proof of this, this is just what I think is happening. I think the decrease may be happening because people with hepatitis C have just died. And so it's not it's not sort of a happy thing that the HCC incidence is decreasing. It just is reflecting the fact that people died of cirrhosis before they died of liver cancer in other racial groups. But as I mentioned, African Americans are less likely to develop cirrhosis before they develop hepatocellular carcinoma. So I think that may give them, I think they may be surviving better than other groups. And that may be why their liver cancer is not decreasing at the same rate. Did what I just say make sense, or did I give a confusing explanation?
No, no, that made sense. Thank you so much.
So are there any other questions? Okay, if not, I'll go on. So there are many barriers to effective surveillance, and they're at so many different levels. So one problem is that ultrasound, which is the method advised by the AASLD, is actually not a sensitive method at all. And it actually misses most small tumors, which is tumors less than 2 centimeters. So providers are not that happy about the methods that are available for screening. And I think this is one of the reasons why screening rates are very low. Then, as I mentioned, screening is a combination of ultrasound with or without AFP. And AFP measurements have poor sensitivity as well. So the first 2 points here just point out that we really need better screening methods. The third point really points out how little confidence providers have in the guideline concordant methods, so that 60% of providers in the United States, I have expressed skepticism about the guidelines, and they actually screen their patients using CT or MRI, which are much more effective and sensitive. When patients have been asked about screening, they mention many barriers, and I've listed some of them here. Scheduling is a problem. They're worried about cost. They're not sure where to get tested. They're afraid of getting tested because they really don't want to find out if they have cancer or not. And as a result of all these barriers, only a small percentage of patients with cirrhosis receive twice annual screening. This is really a low percentage, just 10 to 20%. And then we've got the added problem that the guidelines only advise screening for people with cirrhosis, and not all HCC arises in people with cirrhosis. So we did, these three are my 3 colleagues here down at the bottom, Pani Perumaswamy, Sarah Lewis, and Brooke Wyatt. We did an analysis of surveillance in people who were cured of hepatitis C here at Mount Sinai. And what we found was that after they were cured, Black and Hispanic patients were less likely than whites to receive serial surveillance, which obviously is what you need to have if surveillance is going to be effective. And what was associated with serial surveillance was having private insurance. This is a study from the VA, and it highlights that in the VA system, Blacks were also less likely to receive ultrasound surveillance than whites. And this slide just sort of highlights the barriers that need to be overcome to increase early detection. So we very much need better surveillance methods. Ultrasound and AFP are insensitive, but I want to emphasize they're much better than nothing. So one cannot give up to despair and nihilism. If an individual has serial surveillance by ultrasound, the likelihood of early detection is much, much better than if they don't have surveillance at all. So we need better methods, but we need to use the methods that we have until better methods are available. Additional barrier is twice annual imaging is costly and it's very difficult on patients. So we need a lot of support. An additional problem is that many cases of cirrhosis are not diagnosed. Probably at least 50% of people in the United States who have cirrhosis have not been diagnosed with cirrhosis. So they're obviously not going to get screened. And also, not all high-risk patients have cirrhosis. And these guidelines may not be equally appropriate for all racial and ethnic groups. So we're working, and we'd really like to work with you at the Alliance over the years ahead to overcome some of these barriers and really increase early HCC detection. So one of the things that my group has worked on for about the last 15 to 20 years is the difference in how liver cancer presents in African Americans and other people. And we did a series of studies, and I'm just going to provide some information from a study that we did looking at people with hepatocellular carcinoma who had hepatitis C infection. And what we found was that at the time of liver cancer diagnosis, the liver damage was much, much less in African Americans than in other people. So this slide is summarizing imaging data. And over here, I've highlighted some of the abnormalities that occur in patients with advanced cirrhosis. So when you have severe scarring of the liver, blood that should easily flow through the liver cannot flow so easily because of the scar, and it backs up in other blood vessels, such as blood vessels around the stomach. And these blood vessels are not really equipped to carry the load of blood, and they're likely to rupture and cause bleeding. So these expanded blood vessels are called varices. And another problem that occurs because of the resistance to blood flow through the liver is that fluid called ascites fluid builds up in the abdomen. And when patients have this condition, they need to come in on a weekly basis or so and have this fluid drained. So whether you're looking at ascites or whether you're looking at varices, this overall condition of resistance is called portal hypertension. You can see that the numbers are much, much better for African Americans than for the other groups of people. So this slide just summarizes that cirrhosis is not just one stage. It's actually graded from stage 1 to stage 4. And what we're trying to highlight is that African Americans are more likely to develop hepatocellular carcinoma back here, even before they develop cirrhosis, or with early cirrhosis than other people. But despite their better liver function, their tumors are larger and they're more advanced. This slide just gives some of the characteristics of the tumor, showing that they're bigger, they're likely to be more of them, they're likely to be invading into the vasculature, which is a very bad prognostic sign. They're more likely to have metastasized places outside the liver, more likely to have tumor in both multiple parts of the liver. And this final point being outside Milan criteria, that's very important, because if you're within Milan criteria, the chances that you can have curative therapy by liver transplantation go up. So if you're getting diagnosed and you're no longer within Milan criteria, that is a disadvantage for you. And in our study, we found survival was worse for our African-American patients here at Mount Sinai. So that's our study, but it's really consistent with lots of other work showing that liver cancer has a distinctive profile in Black patients, and that there's less advanced liver disease. This is a study that was done in Miami, and they're down here looking at cirrhosis. And as you can see, about 77% of Blacks had cirrhosis, but almost 90% of whites and over 90% of Hispanics had cirrhosis at the time of liver cancer. This is another study really showing the same thing. So in this case, African Americans, 80% had cirrhosis, whereas in Caucasians, 90% had cirrhosis. And you can see, again, I mentioned about ascites, less likely to have ascites. There's a condition called encephalopathy, which is a kind of extreme brain abnormality that occurs with advanced cirrhosis. Less of that in African Americans, less of these abnormal blood vessels, the varices in African Americans. So this was a tri-institutional study from Stanford, Mount Sinai, and the Mayo Clinic. This slide shows some information from the VA system. It looked for people who developed liver cancer without cirrhosis, who had hepatitis B as the underlying cause. And what they found, looking at patients specifically with hepatitis B and people who developed HCC without developing cirrhosis, they found that this was more likely in African Americans. So we're really curious to know what could be responsible for this atypical presentation of HCC in African Americans. Why do they have better liver function, but they have worse liver cancer? So I think part of the answer is that African Americans have genetic factors that protect the liver from fat accumulation, inflammation, and fibrosis. And I'm going to present a little data, but they have more exposure to toxins that cause liver damage and possibly are more vulnerable to these exposures. So again, getting back to the concept of two sides of the same coin, a recent study, this study done in Finland, so it didn't include any African Americans, looked at genetic polymorphisms that were related to serious liver-related outcomes. And they found 7 polymorphisms, and I'm just going to highlight one of them. And it's part of a larger study that we're doing that shows that African Americans generally have low frequency of alleles that are associated with accelerated liver disease progression. So this slide shows the global distribution of genetic polymorphisms in a gene that's called PNPLA3. And you might have heard about this gene because it's very prevalent in Latinos. You can see the risk allele is present in almost half of Latinos and a quarter of European Americans. And this allele increases the deposition of fat in the liver. So it causes steatosis. It's a risk factor for NAFLD and a risk factor for NASH. And what this slide shows is that if you have 2 versions of the risk allele, your likelihood of having severe liver-related outcome goes up 2.5-fold. So it's a very strong risk factor for the progression to cirrhosis. And you can see here that African Americans rarely have this risk factor. So again, I think this is contributing to their lack of progression to advanced cirrhosis and fibrosis. And this is just one out of several genes that show a similar trend. So on the one hand, I think African Americans have a set of germline alleles that are relatively protective against progressing to cirrhosis. So we want to know, well, what is causing their liver disease if they have generally protective alleles? And we're very interested in the possibility that toxic environmental exposures are leading to liver disease, especially in African Americans. But before I go on, I just want to stop again and see if there are any questions. Anybody wants to unmute and have a question?
There's nothing in the chat, but
Okay.
I will keep I'll
Okay.
keep watching.
Sounds good. So we looked at toxic exposures in a national data set called the National Health and Nutrition Examination Survey. This is a great service of the United States government. It provides this study, these NHANES data sets provide a very high percentage of what we know about nutrition and health and disease in the United States. And the data sets are publicly available, so we just downloaded them. And we screened within the data set for people likely to have advanced liver disease using a combination of the FIB-4 score, which I mentioned before is a non-invasive metric for estimating fibrosis stage, a second similar tool called the Fornes Index, and we combined that with ALT elevation. And the reason that we used this as our threshold for identifying people who had advanced liver disease is really based on studies that come out of Scandinavia, where they showed that this combination of high FIB-4 or Fornes with the ALT elevation had a high accuracy for identifying people who were going to have a serious liver-related event in the next 10 years. So this is my graduate student, my wonderful graduate student named Ma, who's done all this statistical analysis. And this picture up here shows the mobile vans that the NHANES study group uses to go around the country and collect data. So we ended up with a very large study group with about 47,000 people and about 640 with advanced fibrosis. And when we looked to see who had advanced fibrosis, what we found was that in the population, the total population, African Americans were about 40% more likely to have advanced fibrosis than whites, and they had higher prevalence of advanced fibrosis, whether they were male or female, and it didn't really matter what age group we looked into. African Americans just had more fibrosis than whites. So we were very interested in toxic exposures. And as I mentioned, toxic exposures include smoking, excessive drinking, lead, cadmium exposure. And what we found in our NHANES study was that several toxic exposures were associated with advanced fibrosis in multiple groups. But we also found that non-Hispanic Blacks had a distinctive pattern of conditions associated with advanced fibrosis. And one of the big surprises is shown here for BMI. People always think, well, I don't know. I think we tend to think of obesity as a risk factor for liver disease. But surprisingly, what we found in our study was that it was African Americans who had a normal weight who had a higher prevalence of advanced fibrosis than African Americans who were obese. And that was highly specific to African Americans and not something that we saw in any other group. So we turned this investigation around a little bit, and instead of looking at who had fibrosis, we looked at who had factors that might be associated with liver damage. And what we found was, unfortunately, for the majority of the conditions that we looked at, conditions and exposures, serious exposures were more prevalent in African Americans than whites. So African Americans were more likely to have kidney insufficiency, diabetes, hypertension. They're more likely to be obese. They're more likely to have a high waist circumference, former drinker. And then importantly, they're more likely to be living in poverty. They're more likely to have high lead exposure, high cadmium exposure, and high exposure to polychlorinated biphenyls. And probably this entire list of adverse health conditions is one of the reasons why life expectancy is so much lower in African Americans than in whites. So we then did multivariable analysis to look to see if we could find factors that were independently associated with advanced fibrosis in African Americans. We found that exposure to lead increased the odds of advanced fibrosis over 4-fold, so very high risk. So I'm just wrapping up, and these are my main points. HCV remains the leading underlying cause of liver cancer in the United States. Cure reduces risk, but not as much as you would hope. Among African Americans with viral hepatitis, liver cancer has an atypical presentation with less advanced liver disease and more aggressive tumors. Surveillance is arduous, but should be vigorously pursued because it can lead to early detection, and early detection can lead to curative therapies for HCC. African Americans are less likely than whites to undergo serial surveillance, and barriers include lack of private insurance, but we'd like to propose that this atypical presentation may also be a barrier. And we just want to highlight our data suggesting that toxic exposures may be disproportionately important drivers of liver disease in African Americans. And this slide just highlights my colleagues, in addition to Ning, who've worked with me on these studies. So if there are any questions, I'm happy to try to address them.
I don't see anything in the chat now, so I'll just keep an eye out for that. But if anyone would like to unmute themselves, if you have a question, please feel free. Well, thank you so much for that talk, Dr. Branch. That was really eye-opening. A lot of new information. So I really appreciate that. Let me see here. Now, it doesn't look like I have any questions now, but are you okay if we email you with any questions?
Absolutely, that would be fine.
If anyone has questions for Dr. Branch, that you think of later on, please don't hesitate to reach out, and we can get that to her via email. And then, does anybody have anything else to add as far as what's going on in their world with HCV? Okay, it doesn't sound like it. So, on July 18th, Tuesday, July 18th, we'll be meeting again at 10 a.m. I'll send an email reminder out with a link on that as well. And I will send a follow-up link later today following up this presentation. So Dr. Branch, again, thank you so much for your time and sharing your info with us.
So thanks for inviting me.
We really appreciate it. Thank you.
Take care.